of this public forum. Okay. Alright, so the second half of the session will be starting off with something that is very important these days. Okay, the need to be more aware about breast cancer. Alright, the woman's breasts are very symbolic of femininity. Okay, breast cancer, however, is the most common cancer that women face these days. Okay, finding a suspicious lump can definitely be very scary. Okay, but fear not. Okay, most of the time it's not cancer. It can be due to other benign conditions as well, i.e., non-cancerous conditions. So we have with us today Dr. Radhika Lakshmanan, who basically will tell us more about breast cancer. She is a general surgeon with more than 18 years of surgical experience. Her subspecialty lies in the treatment of breast diseases, ranging from the management of benign breast lumps and breast conditions, such as breast cysts, breast lumps, abnormal nipple discharge, and problems with lactation. Okay? On the occasion, she even sees men with abnormalities in their breasts. Okay? And of course, breast cancer. So as a breast specialist trained in reconstructive oncoplastic breast surgery, her surgical technique allows for removal of cancerous lumps and tissue while attaining the optimal aesthetic outcome. Okay, so Dr. Radhika?
Hi, good afternoon everybody, ladies and gentlemen. Thanks for the introduction, Ashley. So, I hope you had a good tea break because I'm going to move you up from the bottom part to the top part. So, yeah, it's all about being a bit more aware of your breast and breast cancer. And why is that so? Because I think you know this, most of you will know this already, it's the commonest cause of cancer in women in Singapore and in the world. Followed by the rest of the diseases, colorectal, uterus and cervix actually. Lower down the list. Breast is actually top for women, and it's also the commonest cause of death in women for cancer, unfortunately. So I'm just going to run through the topics, the subtopics I'm going to go through with you. That's really done, is the commonest cause. Some of the risk factors, how somebody can present with cancer, how you know that, oh, this is the time that you need to go and see the doctor if something is wrong. What are the investigations that we have? That's also part of the investigation screening tools. And what is a biopsy? And when people talk about biopsies, a lot of women get frightened. What was it all about? Something about advanced scans that we do after somebody has cancer, and the treatment. Very briefly on the treatment. Okay. Risk factors for breast cancer can be broadly divided into three main categories. What does this mean? Estrogen imbalance. Basically, if you have all this, you are kind of protected from breast cancer. That means you have, late menses, you get married early and have children earlier. Many children before age of 30, if you breastfeed for more than 6 months, you have earlier menopause. Actually, those things protect you against breast cancer. It does not mean that if you do all that, if you have many children, you breastfeed, you still does not mean that you do not get cancer. It's just the risk drops quite significantly. What is environmental? That's basically lifestyle. I'll go through that in the next slide. And I just want to highlight that this pie is very small. So a lot of women come to me in the clinics and say, why did I have cancer? There's no one in my family who has cancer. Why did I get cancer? Actually, the genetic cause is actually very, very small. It's less than 20%. So which means that anybody, I'm afraid that anybody on the street is at risk of breast cancer. It's not genetically transmitted. That percentage is actually very, very low. So I'm going to highlight on the risk factors on lifestyle. This is mainly this in summary. So smoking, chronic smoking is a very high risk factor for cancer. Alcoholism. Obesity is also associated with cancer. Exercise, right? So hence, exercise and healthy lifestyle actually protects you against that. right? These are factors which you can have an impact, you can change. Whereas things like early menses, these are things which you can't change. You know, the estrogen imbalance, something which you can't change in your life, perhaps. But the environment is something that you can do, and you can do it right now. Okay, so if you're a smoker, you can try and cut down on the smoking. If you have a sedentary lifestyle, do some Pilates, do something at least, something which keeps you moving about. You know? So those are things which can help you. Again, these are risk factors. It does not mean that you do have a healthy, fit woman, why did I get cancer? These are things which help reduces it. The mission to reduce it. Now, I'm showing this slide because this is something we don't really want to happen. Stage 4 breast cancer means that the treatment is a bit too late. The cancer has spread from the breast to elsewhere in the body. Commonly, it can spread to the lungs, it can spread to the liver, it can spread to the brain even, and the bones, and what we call the lymph nodes in the neck. So we don't want this to happen. So you need to catch it early, right? If you catch it early, then the treatment and the outcome is a very good success rate, which means the survival and the success of the treatment is very high. So which means it is not a death sentence. Stage 4 is unfortunately almost considered death sentence. So you want to catch it before that. So how do you want to catch it before that? You need to go for breastfeeding, right? Why do you need to go for breastfeeding? Because I've said that early breast cancer, they're not like colon cancer or stomach cancer, where you have problems with the tummy, you have vomiting, or you bleed from the bottom. There's no signs. You look perfectly as good as normal from today to the next day that you're diagnosed with breast cancer. They don't show up because they're so too tiny. They don't impact on your whole body, right? So nothing is, you can't tell. So that's why breastfeeding is advocated. So what does breastfeeding refer to? It refers to X-ray of the breast. That's what we always call the mammogram, right? And the recommendation from Ministry of Health guidelines is yearly if you're between 40 to 49, and 1 to 2 years if you're above 50. So what is X-ray of the breast, mammogram? Some of you may have gone through it, some of you may not have gone through it, some of you may have heard that, oh, it's too painful, my friend said it's too painful, I'm not going to go for it. Very common, I hear that all the time. But that's the best tool we have right now for women above 40 to screen for cancer. Okay, so it's basically an imaging plate which is pressed between the breast from side to side, top to bottom. Okay, that's what is a mammogram. It takes less than 10 minutes to do that. Having said that, any investigation is not, it's not foolproof. Okay? If any one of you have done it before, you would have seen in your report, at the bottom they will always quote 8 to 10% of cancers are missed on mammogram. Okay? So unlike somebody's tumor is as big as that, okay, tiny cancers may still be missed, or some cancers are just not picked up by mammogram for various reasons. One of the reasons can be, if you saw the Straits Times a few days ago, there was an article on dense breast. So a lot of women in Asia and Singapore have what we call dense breast. The breast is very thick. So when it's very thick, when you do a mammogram, it's lost in the thickness. It cannot be seen. It's like a cloudy pond, and you look into the pond, you can't see the fish, but the fish is actually inside. It's just not picked up, right? So when you have a dense breast, more often than not, there's a chance that the cancer can be missed. So nowadays, most of us advocate ultrasound of the breast as well to help to reduce the risk of missing the cancer as a screening tool. So ultrasound is fairly safe. There's no irradiation to the breast. Okay, there's no X-radiation. It's just like how the baby is tested when it's in the womb. So it has to be safe. The baby can be scanned. This is an ultrasound picture of a lady. So this is an ultrasound of the breast. So this lady is actually my patient, and her mammogram was actually normal, right? So if we didn't do the ultrasound, we would have lost or missed this. She actually had cancer, right? slide up because you may hear from your friends and relatives some of these terms, which are not done as a standard tool, okay, but which is done when there's abnormality detected in the main mammogram. So you may hear things like tomosynthesis and MRI of the breast. Okay? And some women may ask me, so MRI is not painful, so why not I just do MRI of the breast as a screening tool? The reason is because by itself they have additional problems, so I'll come to it later. Tomosynthesis is one of the latest tool in cancer detection. It's basically a three-dimensional X-ray of the breast. It's still fairly new in Singapore, very few hospitals have it. Mount Elizabeth Hospital and Raffles, and I think National Cancer Center are one of the few hospitals which have tomosynthesis. So if you remember my previous slide, mammogram is where they do the X-ray of the breast in two views. What this tool does is actually takes a 360 degrees X-ray of the whole 3D of the breast. So the risk of missing lesion is low, number one. Number two is that it also has special software, that means the radiologists look at the computer and try and decrease the thickness of the breast so they can see lumps or cancers which are hiding behind. So that's how special this is. But you can't, we don't recommend this for normal screening. It's only if there's a problem with your main mammogram. Again, MRI breast, you may hear about it, not for routine use, because by itself, it may pick up a lot of other things which may not be cancerous, but may be normal, but put you in a wild goose chase. So if you have some selected types of cancer may require MRI because some cancers have a tendency to occur on the other breast, which standard mammogram also may miss. So only when someone has breast cancer, usually the cancer doctor, the breast surgeon may advise that you may have to do this. So otherwise, we don't normally do MRI breast. Okay, so how can somebody present with a breast problem? That means when do you know something is wrong with the breast, right? Commonest presentation is actually pain. I'm sure all of you must have gone through this sometime in your life. Once you start having menses from a young girl of 15 to even post-menopausal, you can have breast pain. Commonest presentation in clinics. You can have breast lumps, which are little lumps, like little marbles we can feel in the breast. You can have nipple itch, nipple discharge. Of course, because a lot of women nowadays are aware and going for screening for mammogram and ultrasound, you can present with the abnormality on the X-rays. All this can be related to normal abnormalities in the breast. It does not have to be related to cancer. But unfortunately, all this can also present in cancer. Okay? I just want to highlight pain presenting in breast cancer is very, very small percentage. Less than 10% women with cancer present with pain. So which means most breast cancers are painless. So which also means that if you feel that if somebody finds this is a lump and it's painless, it does not mean you're okay. It really does not mean you're okay. I find a lot of women think that, oh, the lump is it's painless, it doesn't do anything to me, I must be okay. It is not okay. Alright? Because 80% of breast cancer lumps are not painful. On the other hand, most of the lumps and most of the pain, as my first two speakers would have told you, has got a lot to do with the female hormones. Right? Because of your menses, because of your cycles, so ups and downs in the estrogen levels in the body. It can cause pain. Premenstrual pain is very common. It can be one side, it can be both sides. About a week, two before your menses, mainly in the upper part of the breast, very, very common. Once the menses is over, the pain usually fades away. You feel the breast a bit lumpy just before your menses as well. That's why if you find that something is lumpy just before your menses, don't get too alarmed. Wait a while, once the menses is gone off, re-examine the breast. If it's still there, then please consult a doctor. If it's gone away, then okay, well and good, probably because of the menses. Right? So I put this slide up because breast abnormalities can happen in any age group. Okay? Of course, the older you get, then the risk of cancer is higher. Okay, but abnormalities as in lumps, which are non-cancerous, can happen in any of these age groups. Teenage girls also can commonly have what we call fibroadenomas. Babies can also have breast problems. If you all remember your kids or nephews or anybody, when even the little baby boy would have a little breast bud, and that's because of the female hormones his mother has passed over to him. Right? Not because he's become a girl or something. Okay, so that's fibroadenoma. This is a diagrammatic picture. If you have gone for screening, this is what they will draw on the ultrasound report. Many lumps. Oh no, I've got many lumps in the breast. Am I in trouble? So when there's many lumps, I would say most of the time it's actually alright. But it does not mean that you take it too casually. It has to be followed up. Okay. Sometimes the doctor will advise you that you may need a biopsy. That means you need a tissue sample of the lump. Sometimes they will tell you that you need to observe it. Sometimes, for various reasons, you may need to remove it. It's very big. So it's good to say the commonest non-cancerous lump. Commonest in less than 30. You can also occur in your 40s. That's how it looks like when you take it out. We call it a little breast mouse. So another form of lump that you can feel in the breast is what we call a breast cyst. This is an ultrasound picture of how a cyst can look like. Again, ultrasound is the little probe they put on the breast. And this black balloon. When there's a black balloon, means there's actually fluid inside. And usually cysts are not associated with cancer. Most simple cysts, we call them, are not associated with cancer. And basically, it's like a water balloon. Quite harmless. Sometimes some of these lumps the cysts can be quite big and cause pain in a woman. So this way that we can relieve that is actually, you have to deflate the balloon, right? So we can do that in the clinic, put a needle in and the lump goes away, cyst goes away and your pain goes away. But we don't have to do that for all the cysts. The cysts can vary in size from 1 mm to 5 centimeters. So the bigger it is, you probably need to deflate it. Having said that, please don't go home with the idea that if I have cysts, I'm okay, there's no risk of cancer. It really depends on the type of cyst. Sometimes some of the little balloons have little marbles inside as well. So the balloon has with the marble is not that great. So if something like that, it may need to be biopsy. Okay, but most of the little balloons are okay. Now come to a different presentation axis. If you remember or you've gone through breastfeeding, high risk of having a breast abscess, which is actually a pus ball in the breast. So if it's small enough, nowadays we can just put in the needle and take the pus out and then give you a course of antibiotics and then you'll be okay. So you need to catch it early. So if any of your daughters or your relatives have breastfeeding and there's a lump which doesn't go in, it's painful, please seek treatment early, because if you keep it too long, then this kind of abscess is just too big, too horrifying. We can't put in a needle, we have to go for surgery. So we don't want that, right? We don't want that because they end up with big holes and dressings and very problematic. So the risk groups are mainly if you're breastfeeding, if you're a smoker, you're also at risk for breast abscess, and if you're diabetic. So if you don't belong to any of these groups and suddenly you have an abscess, that is worrying, right? If you don't belong to any of these groups, suddenly you have a bud in the breast, we are worried as a cancer doctor, we are worried if there's underlying cancer. Okay, so if any of you have that, please get it checked as well. Okay, breast itch, quite common. A lot of women have this, from young to old. I find a lot of young women in the 20s have this, and most of the time, thankfully it's because of a skin problem we call eczema, okay, mainly in the nipple area. Sometimes it can be so bad that it actually bleeds from the nipple area. Treatment is actually very simple. I find a lot of women are embarrassed to see the doctor because they don't want to tell them, the nipple is itching, too embarrassed. But please seek treatment because it can be very easily treated with a cream, and then you're just shocked. Otherwise, you get very bad pigmentation of the nipple area. Right? Now, this is a lady, she's about 70 years old, with complaining of nipple itch. I'm not sure if you can see, but it's a bit flaky, not quite normal looking. Right? So again, in an older patient, if you have nipple itch, most of the time it's not because of eczema. So we are worried again. If you have nipple itch, especially only on one side, in above 50s age group, I think you need to get that checked. So this lady had a mammogram. This is the mammogram, right? And if you see. Can you see these white spots? These are called microcalcifications, calcium deposits in the breast. So these are abnormal calcium deposits. Right? So this was biopsy, and this actually turned out to be cancer. Right? And she had to undergo surgery. Now the other point I want to bring up is that these calcium spots will not be picked up by ultrasound. Okay, because these calcium spots are very small. They are not picked up by ultrasound. So a lot of women who ask me, can I just forego the mammogram because it's too painful, uncomfortable, or just do the ultrasound? The answer is no, because I don't know if there's calcium deposits lurking around, and that can be related to cancer. And it can also not be related to cancer. Fortunately, 80% of calcium deposits are actually non-cancerous. They are not related to food, but because there may be a small link, we generally monitor them. We know when we look at the scans, there are different types of calcium deposits, like there's different types of popcorns. It depends on the shape, how they group together. So depending on the pattern it shows on the X-ray, we can tell sometimes whether it's normal or cancerous. Sometimes when we can't and it's suspicious, then you need to go for a biopsy. And if it's proven, then of course you need the treatment. So how do we biopsy? Biopsy means we take the tissue sample from the breast. So there are various ways we can do that. Okay. Before, traditionally, you go for the surgery. You go for the mammogram. They put a needle inside the breast to locate the area, and then that area is removed by the breast surgeon. Nowadays, you can also do what we call a mammogram biopsy, which is you don't have to go for surgery. It's done under local anesthesia, that means you're awake. The doctor puts in a little painkiller in the skin, the needle goes in and removes the calcium deposits. And that is analyzed, right, in the lab, and hopefully it doesn't come out as cancer. This one is, right, the auntie's one is cancer. Now, other ways of biopsy. So one of my patients actually told me when I told her that she needs a biopsy that before I did the biopsy, she heard a lot of horror stories about it. Actually, it's very painful, very horrendous, and actually it's not. The doctor won't tell you that you need to do a biopsy unless it's necessary. The reason why you want to do it is basically to make sure there's no cancer lurking around. It's when we are not sure with all the scans, or it's suspicious looking that it's probably cancer that you need a biopsy, because that's 100% proof the tissue inside the body is bad. So usually, again, it's if you have a lump, needle goes in, numbs the area, small cut, slightly bigger needle goes in, and the tissue comes out, takes about 20 minutes, and it's done with the clinic, and the tissue is tested. Another way we can biopsy lump that's found on ultrasound. So this is a lump found on ultrasound. Again, we put the mammogram needle in. You don't have to go for surgery. So it's done, you're awake, local anesthesia, needle goes in, sucks out the lump, and you go home. Right? So you don't need the cuts in the breast, you don't need to go under a big anesthesia. But having said that, it's only limited, only for certain cases. Right? Not all breast lumps can go for this needlescopic kind of technique. It has to be pretty small, very, very small, less than 2 centimeters. And we must be quite sure that it's probably not cancerous. If it's cancerous, we don't usually recommend to just do that. You probably have to go for surgery. And we have multiple small lesions, you can also do that. It's only a day, it's not day surgery, it's actually a clinic procedure. So what do all the doctors do with the biopsy, right? So when you do the biopsy, if it's normal, it's very good, go home. Sometimes it may need to be followed up because some lumps, even though they're not cancerous, they have a tendency to put you at a higher risk of having cancer in future, so you need to be followed up. So if it's bad news, then it's cancer treatment. So I want to go to a brief overview on cancer treatment because I find that there's a lot of misconception in the public about cancer treatment for breast. Firstly, actually, it comprises of a whole cocktail of treatment procedures. It's not just surgery or it's not just chemotherapy. It's usually a combination of treatment. The other thing is that the chemotherapy, when I mention chemotherapy to my patients, that's, oh no, I'm not going to make it or something like that. I just want to highlight that chemotherapy refers to medication that goes through your body to kill off the cancer deposits, microscopic cancer deposits in the body. And this medication we use very different drugs for colon cancer, we use different drugs for pancreatic cancer, we use different drugs for breast cancer. So the cancer drugs are not the same. Okay, so when they're not the same, the effect is not the same, the outcome is not the same. So you cannot compare someone who's got cancer of the stomach, stage 3 cancer of the stomach going for chemo, with someone with stage 2 breast cancer going for chemo. You can't listen to the person because the person says, I didn't make it. That's very different because the treatment is very different. So please do not compare chemotherapy with different cancer types because the outcome is different, your benefit is different, the prognosis is very different. Okay? But I just want you to remember that actually it comes with a cocktail. It's not just one of it. Sometimes we reverse the mainstay is actually surgery. Sometimes this one goes the other way around. Chemo comes first, then surgery comes later. It depends on how advanced cancer is. The other thing I want to highlight, it does not mean you lose the breast. Okay, it really does not mean you lose the breast. And that's why it's important to go for screening because if you pick it up early, the chances are that you don't have to lose the breast. If you pick it up late, if the whole breast is involved or half the breast is involved, there's not much doctors can do. So even if someone is in the situation of losing the breast, you can always opt to reconstruct the breast. You can do a total breast reconstruction. There's various techniques of doing that. Some people just don't want to do anything that's up to them. Don't do a reconstruction. The other one that we do is, of course, you just remove the lump. And after you remove the lump, you have to go for what we call radiation treatment, which is heat treatment to the chest wall. And also we remove the lymph nodes in the armpit. And that's part of the total breast cancer operation. So a lot of women think that breast surgery is a lot of big ugly scars. I think it's going to give them ugly shape. It's embarrassing after the surgery. But thankfully, because of some surgical advances, something that I'm interested in, which is oncoplastic breast surgery, where you combine a lot of aesthetic techniques in the cancer operation, so that in fact, who I trained with before says, you actually you buy one, you give, and actually you get something better than what you had before. And that's our aim actually, because you already hit with something bad, you already hit with something as bad as cancer, and you get back something a bit better to go home with. So we try and give a bit more of a better outcome than the standard surgical techniques. Now I put this up, just now I showed you the whole thing that it's usually a cocktail of treatment, and then suddenly I tell you it's chemotherapy required. You probably might know that most patients end up having chemotherapy for breast cancer, but now we've got a new tool. Okay, you just need to, if you can remember, the name is Oncotype DX tool. It's actually a special tool which assesses the breast tissue which you've already sent for testing, and it assesses the prognosis of the cancer. Now it may seem a bit complicated, so let me just put it in maybe a different analogy. Like, if you have a basket of fruits, you have like apples, oranges, you have durians, you have bananas. They're all considered fruits, right? But their all characters are very different, right? Durians can actually prick you, can hurt you, right? Oranges are, or apples are very benign. So likewise, breast cancer, there are actually many types. Although we say breast cancer, there are actually many different types of cancer. And some select group of cancers, we can do this special test. And when we do the special test for the select group, the chemotherapy may not be sure that it's not required. So that means only surgery may be required for those cases. So this is a recent advancement in the last 5 to 8 years that we have in Singapore. So this has to be discussed with the doctors when someone has cancer. Okay, so coming to another aspect, so if you remember my earlier slide, genetic screening for genetic causes of breast cancer is actually very small, it's less than 20%, but nevertheless there is, and maybe it's good to know a bit about it. There's a tool to detect whether you have the cancer gene, and we don't normally recommend the genetic testing for anybody, only if you are at very high risk for getting breast cancer. So that refers to if you have a very strong family history of breast cancer. Strong family history refers to if your mom or your sister, your direct first your primary relatives are affected. If your second line relatives are affected, like your aunt, uncle, maternal aunt, maternal, a few of your maternal aunts, that's second line. A few of them affected is also considered strong family history of breast cancer. If you have one aunt who's affected with breast cancer, that's not considered strong family history of breast cancer. That's because cancer is the commonest cause of cancer. And if somebody has cancer in the family less than 40 years when they first had it, probably you might also want to think of genetic causes. Or someone first newly diagnosed age 35 breast cancer, you might want to consider doing a genetic screening. Or you have cancer in both breasts. So these are the cases where we will advise to do for genetic screening. So what does it involve? What does it mean by genetic screening? Basically, it's a simple blood test. It can be done in the clinic. Results generally out in about 2 weeks. So all these tests may be easy to do, but then the implications may be a bit more difficult to go home with. Now, if somebody has a BRCA1 and 2 gene, what does that mean? It actually means that there's a 50 to 80% chance of getting breast cancer in the lifetime. So if somebody tests at the age of 30, the lifetime risk of getting cancer is 50 to 80%. We are not sure when the person is going to get it, Will she get it when she's 40, when she's 70? We don't know. So that's the meaning of lifetime risk. The positive for both is the risk of ovarian cancer, risk of pancreatic cancer. Pancreas is an organ found behind the stomach, required for digestion of your food as well. So that's what it means. On the other hand, also you can revert and think about it. So there's a 50 to 20% chance that you don't get cancer in your lifetime, even if you're genetically positive. So it really depends on how you look at the glass, whether it's half empty or half full. So of course, I think all of you know this, right? The Angelina Jolie effect. So she tested positive for BRCA1 and 2. She took a very dramatic step of removing both the breast and both the ovaries. I think it's quite easily said when I'm standing here that you can do that, but it's not easily said when you're on the receiving end to go home and say that, oh, I just take off the breast and ovary. It's not a very easy thing to do. You need a lot of strong social moral support, right, for that to happen. So it's not necessary you do that. The other option is that you can go on high alert screening, which means if somebody above 40 go for screening yearly, high alert screening would mean actually twice a year of imaging, that means some sort of x-rays, and maybe 3 times a year of seeing the doctors. There's no fixed rule, but it's a bit more closer monitoring. That's the other thing that you can do. So I thought I shouldn't leave the men out, so I should have some slides. Male breast cancer, right, just to complete that. Good thing to know is they're very rare. Of all the breast cancers, male breast cancer, only 1% is attributed to male breast cancers. Usually in much older groups, when they're more than 60 years. So if you be surprised when you're married, you can still do a for mammogram. It's still possible. We will usually contract with the ultrasound as well. Treatment is the same. Once you have breast cancer, the treatment is a whole cocktail again, and depends on when we find the cancer, how bad the cancer is. So I think that's the end of my slide. So some take-home messages is, I think we know that already. Early detection improves outcome. I forgot to mention just now in my screening slide that so screening means you go for mammogram, you go for ultrasound, right? And then you find the result and then you go home. But if you have any problem, any symptoms, like you have a lump, you have some discharge, you have some itch, don't go for screening and then go home, and then the screening result comes back as normal and say, oh, I've got a bit of a lump there, but then they say the x-ray is normal, so I should be fine. No, that's not correct, because that wouldn't be screening. So if you have a problem in the breast, that's not considered. Screening means you have totally no problems in the breast, go for the x-ray. But if you find there's a lump, you have to consult the doctor, because the x-ray can miss 10 to 15% of cancers. So if the x-ray misses, you don't tell anybody. We can't go to the more high-fi tools like the MRI breast or the tomosynthesis, which I mentioned. So that's why if you find something, you must see the doctor. Don't just go for the mammogram ultrasound and be happy that, oh, it's normal, I should be fine. Could have missed something. Okay? So screening only if you don't have a problem. If you have a problem in the breast, please see the doctor, please see the breast doctor. So there are advances in surgery, so the treatment is not so disfiguring. Okay, nowadays not so disfiguring. Chemotherapy has also improved a lot over the last 2 decades, actually, 2 decades. So you don't have women lying down in bed being very sickly. My patients they actually still go to work, some of them, or they work from home. So it's not like end of the road if you have chemotherapy. It really is not. And improves survival if you find it early. And there's always life beyond cancer, which I didn't mention just now. Right? The aim of cancer treatment is to have you integrate back into society, back into doing what you used to do again. So the other thing is that I find that some of my patients, I know that relatives are very concerned for their parents or their siblings. So they tell them, oh, you have cancer, so you don't do this, you don't do that. No, actually, once the surgery is over, once the chemo is over, they're okay to do things. They only need certain restrictions, If they want to go back to work, let them go back to work. Otherwise, they'll feel like they're ostracized, It does not mean you have cancer, you should be ostracized or you should be protected. It's only that period of the treatment period that you need to be protected. So please let them continue with their life. So there's always life beyond cancer. You should take a peek at the Breast Cancer Foundation members. They have very high activity lifestyle, more than a lot of us actually. Okay, with that, thank you very much.
Alright, thank you Dr. Radhika for the very interesting talk about breast cancer. So I hope if